There we go, red light on.
Lovely. Well, welcome everybody. As usual, our meeting is being recorded because it will be available on the NHFT website. We do like members of the public to be able to watch it back, and indeed governors who weren't able to attend as well. So just be aware that it is available for public review. We have had a few apologies for this month's meeting. Apologies have formally been received from Sheila Begley, Rupal Shah, Summer Maradzika, Monica Maparanyanga, Pat Marshall, Richard Amponza. But I think we are corporate today, so warm welcome to everybody who was able to make it. We do have apologies from our Chief Exec, Angela Hillary. I believe she's presenting at a conference today, but ably represented by Dave Mayer, our Deputy Chief Exec, who is in the room with us today. Just to say that on the assurance item that will be on our agenda today, it is item number 8. I think it's actually going to be Robin Burgess and Joanne Lancaster who are going to be leading that item, just in case Julia was panicking that it was down to her, but we had agreed a slight change to that. So just wanted to make you aware before we get going. So declarations of interest. If there are any declarations specific to items on the agenda, you have an opportunity to raise that now. Otherwise, we do have paper A available just for the public record, and just a reminder to governors that if you do have any additional declarations to make, then please submit them to the usual email address, which is the Foundation Trust email address. So we have paper B, which is the minutes of our last meeting. So just check with everybody that they are content. We are content that the minutes are an accurate representation of our last meeting. So unless you indicate otherwise, I'll take that as approved. Everyone content to sign those off? So thank you very much. We have no open actions on our action log, so no matters arising to highlight to you. Okay, so without any further ado, we've had a very interesting range of governor stories at our previous meeting, and I'm delighted today to introduce today's story from Michael Fanning. So I'm looking around the room, make sure, yes, I can see Michael, and Michael's nodded, so I think he must be ready to go. So delighted that Michael has agreed to present the governor's story today. And usually it's a great opportunity to hear from governors about their experiences, why they've become a governor, and their often lived experience as well. So Michael, really pleased you agreed to step into the shoes today. So over to you, please.
Oh, thank you, Krishni, and good afternoon, everybody. It's a bit of a wet day, and I don't know if anybody has just rushed from the NHS providers governors day today. It's been a really interesting day, so I just wanted to say happy volunteering week and thank you to everybody's contribution. It's been a really, really thought-provoking day, and lots of ideas. So don't be surprised, Krishni, if you get bombarded with all sorts of ideas and suggestions. But before I start the presentation, what I did want to say was it just made me realise also for Northamptonshire, sorry, can't get my acronyms out. Actually, there are some really great things that we are doing, particularly I think around the NED, the quality assurance visits, and the pledges as well. So I did try to, raise the flag for the trust as well. So, that was and it's a good introduction actually in terms of volunteering and becoming a governor. So if I could have the next slide, please. So it's actually, there's a lot here in terms of background, but hopefully this will just give you a flavour, a little bit about me and basically where I'm coming from, because I think as we work with governors, we get to know each other. And I'm obviously very impressed with the governors from the locality. So I will come on to it later, but my role is public governor for the rest of England. So in terms of some motivation, I started my career as a student nurse. I'm happy to say back in 1980, and the Nivea is working very well on me. But what that actually was, it was a very unique experience because at the time, I was the first male nurse to train in the hospital. And I left home at 18. I started my training. I was extremely naive. I knew nothing about equal opportunities or anything like that. But during my training, I wasn't allowed to go to certain areas for my clinical training because I was a man. So actually, I had to go to a different training school, and particularly for maternity as well. So I think from an early stage that really brought about a very sort of questioning, sort of challenging sort of approach to me in the NHS. And on reflection, I think it's a useful context because I think that sort of challenging question, hopefully in a constructive way, has always been there with me. I primarily worked in acute hospitals ranging from small district general hospitals to large university teaching hospitals in London and in Oxford as well. And I suppose latterly, my clinical career, I should say, although it was brief, was as a volunteer vaccinator during the pandemic. I could talk for ages, and I know you know that I can talk for ages, but I think that my career, and I've sort of split this into management career, but what I would say is it's always been the underlying philosophy of being a registered nurse has been with me throughout all of my career. And I think if you're in a clinical role, you just bring that with you into all aspects of your work. So in terms of training and quality, governance, etc., etc. And I have worked as a newly qualified nurse back in 1983 and progressed to being an executive director in South London, a very challenged organisation. And I would say that latter role, I thought I had experienced an awful lot of challenge in the NHS. But when I went to work at that organisation, it was particularly challenged. It was known for being a challenged organisation. But I think the exposure to some of the diversity challenges was new to me. But what I really found was that if you embrace the organisation and the community of that organisation, it certainly embraced you as well. And it doesn't matter how senior you are in your career, you are always learning, and there are some really great people around, including the public, who are there as your critical friend as well. So I learned an awful lot about that. I've always enjoyed writing for publication in terms of some of the professional magazines, and I had a chapter published as a contribution about non-medical prescribing, looking at that from a governance perspective. And apologies to colleagues who may be thinking I'm talking too much in professional language, but I'm happy for you to ask me about that. And latterly, I did start my doctorate in nursing. I completed 2 years of that, so that gave me a really great grounding in research and research methodology. And the reason I stopped it was because I really felt it was literally becoming academic, because not being in a leadership role, one thing you do find when you leave the NHS, it's like a family, but when you leave the NHS, your networks quickly change, and your sort of current contacts and what have you also change. So it's a bit like you become a long distant relative of that very close family. So I found that it was quite difficult, because my research interest was to look at the lived experience of senior nurses, so nurses in executive roles and across the integrated care boards, around collaborative leadership, because I truly believe where we are now and where we need to go, collaboration is essential, but collaboration isn't necessarily something that comes to people naturally. So rather than boring you with my research interest, I'll sort of move on. I think, oh, sorry, if we just go back to the previous slide. So just very quickly to say that my breadth of experience has been across mostly NHS hospitals. In the old days when we had health authorities, I did lots of projects and learned a lot about the politics of health when I was doing some of those projects. When I worked at the Department of Health, I have to say that was probably one of the unique experiences, because you really get to see how health policy is implemented, and you're working with people across all ranges, and some people who've never stepped foot in a hospital, but actually what they're doing does have an impact on all of our lives. So I have to say that was a very unique experience. For those of you who can remember the Mid Staffordshire, I'll call it scandal, because that's what it was referred to at the time. When I was working at the Department of Health, I got seconded to work with a small team of civil servants to produce the nursing response to the report. And somewhere in Hansard is a line, because when the Secretary of State for Health at the time stood up, he used a sentence that I wrote. So I feel very proud of that. Currently, my roles very much have moved into the voluntary leadership roles, and this year becoming the board of a chair for a professional organisation. I've always had an interest in regulation and the judiciary, so I was appointed last year as an independent panel member for the Police and Crime Commissioner, to sit on the cases for serious misconduct for police officers. So that's a fascinating sort of progression as well. And I'm pleased to say that I am progressing in terms of my magistrate appointment. It's been quite a long process, so having been recommended to be appointed, I'm now in the final stages of that appointment process. So I think it's what they now call the rubber stamping stage. So over the next few months, I hope to hear that I have been successful and appointed. I think my motivation for becoming a governor very much is around that wealth of experience that I bring, and very, very deep-rooted in public service. So I think if you've been in public service for a long time, it's very difficult to sort of let go of that. And I think also a move from what I would call from patient to people. So a long time ago, somebody talked to me about patients and people, and when I was in my director's role, I always used to talk about people we serve. And I think labels are important. Some people like to be called a patient, and there's a lot of benefit to that. But I often talk about people who use our services. So that's sort of my phrase. And I just think it brings, it's always brought a very different perspective to me about how I look at things and how we work together for community. I really am a collaborative person. I love working in systems, and I love the sort of challenge that working in different systems brought. And I learned a lot from my last role, again in South London, working with the local authority, because what I learned from working with the local authority is that we can all talk about the same thing, but we use different language, and I had to learn a different language with working with the local authority, and it really sort of opened up my eyes to the we all want the same objective, but for example, my obsession about the Care Quality Commission and quality, the local authority colleagues couldn't really understand that. So I had to learn their language and terminology just as they had to learn mine. And the reason why I pursued my application to become a governor was I did actually apply to NHFT in the past. It was my first application, I think, to become a non-executive. So I didn't make the shortlist, but it was a really good experience. And so I joined as a member, and I kept in touch. And as soon as the trust was advertising for new governors, I had a look and I thought, aha, this is an opportunity. So that's how I've joined you. So the next slide, please. So in things of what do I bring to the council? Well, I like to think I do bring an independent and general perspective. As you know, I don't live in the county, I don't work in the county. But I'm certainly learning about it in terms of the work with the governors, and it's been really great doing the recent service visits as well. So I think that I do bring that different perspective when I ask questions. You know, I'm conscious sometimes I may speak in a very generic way, and that's because, as I said, I don't live in the locality, but I feel that I do understand, and I am understanding and learning a lot of the issues and the challenges. I think it goes without saying in terms of my previous background in leadership and healthcare and governance, etc., etc. I do enjoy the sort of the political side of healthcare as well. Anyway, I think also in a lot of what I do is around influencing and sort of advising stakeholders, and I know that's a jargonistic word, but I think stakeholders is quite a broad church as well in terms of people and strong collaboration. So I think some of those projects that I think in terms of legacy, I think about some of the work that I did in South London with the local authority. In introducing, for example, a borough-wide safeguarding team, so bringing together the local authority and health services to create a borough-wide safeguarding sort of function. So I think all of those things are great fun. I've particularly enjoyed a lot of work that I've done in higher education to bring some of those education services closer to communities and NHS organisations as well. I think that anybody who knows me will know that I'm really, really strong in terms of the accountability and transparency for individuals in terms of what we do, and even as governor volunteers, you know, we are accountable and we have to be very transparent in everything that we do. I love supporting change and really managing relationships. I wouldn't say that I'm an expert, but I have a lot of experience, and I really enjoy getting to know people, what their agendas are, and how I can try and help and facilitate some of those sort of relationships. Yes, I've always have a comment to make, and I think you manage my questions very well, Krishni, during our discussions. But that comes from a very much a point of support to individuals and to the organisation. I think other governors have shared some of their personal experiences, and I'd just like to say to governors, thank you. Some of your experiences, I think, have made me feel quite profound, actually. And I think being very vulnerable and open to being vulnerable to share your experiences, I think it means a lot. I guess in terms of my lived experience, that has been through family members. When I was a teenager, I was still at school. My mum had a physical health problem which manifested into a mental health problem, and that was quite devastating, both for my mum and for me. I can remember her once saying to me, "Please don't ever let me go into such and such a hospital." And she had to be admitted, and I was actually a student nurse, and I got called from my training placement, and was told that I needed to go home. So I think that had quite a profound impact. And my sister, who recently died, was also had a long-term mental health problem. So I think in terms of outlook and sort of health interventions, we always bring that with us in terms of our own sort of perspective and agenda. And I think my recent experience has been supporting a neighbour's son, who's sort of in his early 20s, with some significant issues. And with that, I've learned quite a lot again. I think, in terms of trying to understand a younger person's perspective and challenge, and just offering a cup of tea and a listening ear, and it's very complex. And I think for young people, it's just really brought home to me the significant challenges that young people in our communities experience now. Some of my previous experience in the long distant past was being a volunteer on a telephone help and support line. So I learned an awful lot of skills that I actually learned how to keep a telephone line open for an hour without the individual actually saying anything. And that was due to some great mentoring and training that I had. And I have also been a trustee for a national walking charity as well. I probably only lasted in that role for a year because I realised, whilst I had an interest in walking, you really needed to understand walking to do the role. My role was to be the link with local walking leads and the board of the trustees. And I tried to do it for a year, but I just realised that I didn't have the right background to do that job so well. And I think, when you are in those roles, you have to recognise sometimes that actually you've given it a go, but maybe for the benefit of the organisation, standing down and them trying to find somebody else with the right skill is sometimes the right thing to do. Okay, thank you. My next slide. So what am I passionate about? I make no apologies that I am passionate about being a registered nurse. I'm 62. I still maintain my professional registration. And when I talk to people, and when I used to go and talk to the student nurses, I've always said that it's a privilege to be with somebody at the beginning and the end of their life, and that fantastic journey in between. There are so many opportunities. You can remain in clinical practice. You can be the most senior nurse advisor to the government, and all sorts of things in between. And I'd like to share with you, I was at a recent learning event, a national learning event, and somebody tapped me on the shoulder and asked me if I was Michael from Croydon. And I said, yes, I used to work there. And she said, you're the reason why I became a registered nurse. And she reminded me of a corridor conversation we had, and how I had introduced her to somebody in the learning department. and she went off and did her training. And it's fair to say we both were a little bit emotional. We had a hug, and then it was great to to hear about her story. So you just never know what impact you're going to have on people. Again, I'm really passionate about that support and growth of development of people, fairness. Even as an exec director, I am happy to say I often put my neck on the block, because I think in terms of fairness and sort of due diligence, it was important, and that's your role on the board. Obviously, you have a collective responsibility, but you have to speak your piece, speak to your piece as well. And I think increasingly, justice and community welfare are things that I'm particularly interested in as well. So I think it's fair to say that I think I've reflected that, yeah, I'm really enjoying my journey as a governor. I'm learning. I think we have incredible governors. I love listening to everybody's story and sharing their experiences. I think the lived experiences of not just the governors, but the people that we talk about as well. And the staff, I say our staff, I feel it is our staff. I think our staff here are fantastic, very person-centered. And again, I encourage any governors who get the opportunity to join the service visits, you'll see this. And I think supporting the community, although it may be from, as I say, from a rest of England lens, and also contributing to the board accountability. I think I just refer back to the training day today, and there've been some useful reminders how we can constructively hold the board to account through the non-exec directors. Just as everybody else has worked through their pledges, so have I. Again, I've referenced the service visits. I think my remaining pledge is about participation in surveys, events as well. And I've just completed the mandatory training. And I think in terms of possibly a future focus with my judiciary sort of volunteer career on the horizon, I think I've got a particular interest in prison healthcare. So I think some of the conversations and discussions that we've had have been sort of quite timely as well. So there we go. Thank you very much, everybody. Thanks for listening. And also, thank you very much for inviting me to share my story. I really appreciate it. Thank you.
Well, I think that was our pleasure, wasn't it? And thank you very much, Michael, for sharing your experiences, your insights, and it really kind of gave us a really fabulous picture of some of the journey you've been on. And I know that sort of short slot won't cover it all, but it was really excellent. So I certainly encourage colleagues if they want to ask any questions. But thank you very much for sharing your lived experience, and because this shapes us all, doesn't it? And whether it's through our families or whether it's lived experience that we personally had, it definitely shapes us. But I particularly loved your story about the person you encouraged into nursing, in effect. So you probably didn't know that you encouraged that person into nursing until you met that individual. But isn't that a wonderful legacy to remember? And those small moments where you are reminded about the impact that you can have on other people are so incredibly positive, I think, for all of us. So thank you. Michael, I think Pete would like to come in. So I don't know if Pete would like to comment or ask a question, but I'll open it up.
I've got a question, actually, Michael, that was all. But thank you for that. That was quite interesting and quite moving to actually have somebody come back to you many years later and thank you for. So mostly some people say, oh, thank you, but I didn't really want to do that job. So that was brilliant. I'm just interested to find out, what was the, in the career that you've had, what's the best sort of period that you had throughout the years that you've been a nurse?
Oh, thanks, Pete. Oh gosh, that's a real challenge. I think Well, certainly the early career when you're new, you know, and a bit green around the gills, working, you know, with people and clearly patients. And then I would say, as I got more experience, my time at the Department of Health was fascinating because I was really privileged. The chief nursing officer at the time was a lady, or is a lady, I should say, called Dame Christine Beasley. She retired, but she really took me under her wing, and she really exposed me to some very unique experiences. And that included doing some work with with one of the health ministers at the time of the Conservative reforms. I had to organise filming for the health, for the Secretary of State, I should say, at the time, to do some work to convince nurses and allied health professions around supporting the reforms. I think I just enjoyed it because I'm interested in politics, and to see how a government department works was absolutely fascinating. It was quite a unique experience, and it's not all bad. You know, there are civil servants who really do their utmost to support the public interest. So I think, Pete, that probably was a highlight.
No, thank you. That's great. It's just, I'd imagine looking in on those departments would be quite interesting. I know from my political side. So yeah, thank you.
Thank you, Pete. Ranjit, did you want to ask a question? I saw your hand go up and then it popped back down. So I just wanted to double check whether you still wanted to come in.
Sorry. I just want to say thank you. And thank you for continuing what you're doing, basically. It's a wonderful story.
Thank you, Ranjit. I appreciate that. Thank you.
Thank you, Ranjit. Mabel, please. Hi, Mabel. Can you hear us? Actually, there you are, Mabel. I think we can just about hear you now.
I've put the my things seem to be playing up today. I've put the microphone back on. Can you hear me now?
Yes, we can. Thank you.
I thought that was a fantastic story, but I was very sad about something, that you abandoned your PhD. I really think you should go back and complete it, because I think it is just sad that you haven't. I completed my PhD quite late on, a lot of work, all the rest of it, but I would encourage you to go back.
Thank you, Mabel.
Thank you, Mabel.
There's a challenge for you, Michael, but we'll leave you to decide whether you want to rise to that. But I think you did explain why you sort of decided not to pursue it further. But yeah, I don't know if you want to say any more about that, Michael. I imagine it's quite a big decision when you did it. But congratulations, Mabel, for completing yours as well. So I really just want to add that I think you know, Michael plays a sort of important and slightly unique role, because his constituencies, as he said at the beginning, rest of England, which is quite unusual, and that covers a very wide space beyond Northamptonshire, which is actually important because, as colleagues will know, many of our prison healthcare services are outside of our county. So in many ways, your interest in that, Michael, is well placed. The other thing that I think Michael encouraged, and Robin has picked up in the chat, as we call it, that he had done a service visit with you, and that had proved to be incredibly helpful. So obviously your experience, Michael, brings great supportive insight to what we do, and everybody brings different insights, but obviously you bring a professional background, which we've heard about. So encouraging everyone to do service visits, I think, if they can, with NED colleagues, is a great opportunity to hear from our staff and hopefully get a sense that of their lived experiences and their the way that they engage with you. And I think, Michael, you very eloquently described your experience of that, so that was incredible. And I really would like to also pick up Michael's thread around Happy Volunteering Week, because it is Volunteering Week this week. Great opportunity to thank you, really, because you are all volunteers as governors. You give of your time to us generously, so we really do appreciate that, and it's a good moment to thank you as volunteer governors, but also all our volunteers who make such a difference to the care we provide and the governance arrangements of the organisation. So, Michael, thank you. Really enjoyed hearing from you, and we will continue the thread of governors speaking at future councillor governors meetings, because I think it always brings a kind of rich and varied view of other people's experiences from outside the organisation, and indeed sometimes out of the NHS. Michael obviously had some unique NHS experience. Excellent, thank you very much. So we'll move on then to the next item on our agenda, which is the Councillor Governor's Report. And this is from Richard Smith as our Director of Corporate Governance. It's paper C. Richard will no doubt want to highlight a particular few issues. So over to you, Richard.
Thanks very much, Krishni. Good afternoon, everybody, and thanks very much, Michael, for your story. I'd certainly echo the positive feedback that others have provided. I'll draw out just 5 things from the report this time round, and may invite some governor colleagues to contribute to a couple of them. So, firstly, a very warm welcome to both Mabel and James, who I've seen have joined the meeting, and indeed have joined the council relatively recently. And also a thank you to Mike Buden, who stepped down from his role as a staff governor for the contributions that he made during his tenure. It's great to be able to share a couple of case studies this time around of work that's been undertaken by governors. We've just heard reference to service visits, and included in the report this time round is a wonderful picture, actually, and a write-up following the Stay and Thrive event for the international recruitment team. I couldn't immediately spot any of the governors that had attended that event on screen, but if there is anybody there that attended and wished to elaborate on the case study, then please do raise a hand. It'd be great to hear from you. But clearly here we've had a celebration event for the international recruitment team that have done a sterling job in drawing in new recruits from outside the UK to come and work with us as part of Team NHFT. And I can see Julia was also at the event and is quoted there in the report as well. The second case study then, in lieu of any hands, is from Pete. So as colleagues will probably recall, Pete gainfully volunteered to participate in the Integrated Care Board, or the ICB's community forum on our behalf. It met most recently on the 29th of April. I don't know, Pete, whether you wanted to come in and share any headlines or key messages that you took from that meeting.
Thank you. I found it very interesting in the fact that the people that attended the meeting were from all the different areas within the different parts of the community. So it was great to see a different angle and be able to address certain things. And I know the head of the ICB was there, and they were dealing with a lot of the complaints that were coming through, and dealing with them very well, and explaining the reasons why in the organisation that we're in, things don't happen overnight. It takes a long time in the process. So you will see something 18 months later and go, oh, we finally got there. Why hasn't that been sorted earlier? So that was really interesting. And the changes to the engagement practitioners forum, where they're actually going to look at taking people on to actively pick up the phones and do things. But again, that's got to go through a process and be due diligence checked and everything else. But yeah, it was very enjoyable and very interesting, and we got cake, so I was very happy. As you know.
Bonus, ICB providing cake. That's certainly a new one. But thanks very much, Pete, and thanks indeed for your contributions on our behalf in that forum. We know that the next meeting is in August, so hopefully there's some cake or a suitable cold drink maybe at that time of the year next time around. Moving us on then, the other aspects of the report then relate to sort of the work of the governor committees, which, as the council will be aware, do some particular areas of work on behalf of the council. The first of which, with thanks to Tracy for writing both of these up incidentally, is the work of the Standards Group. So we had a recent meeting just in May, where we undertook an annual review of the work of the Standards Group, and alongside a number of really positive reflections on the difference that the Standards Group has been able to make on the well-being of governors over the past year, were a number of areas of opportunity and of learning. So we can see in the report that not only has the Standards Group reflected on those opportunities for improvements, but also has reviewed its terms of reference. So I won't talk through all of the individual points that have been slightly tweaked rather than completely transformed in the terms of reference, but it's there really for the council's consideration, and at the end, hopefully, the council's approval also. So in addition to the Standards Group, the other group that's been leading a big piece of work for the council is the Membership Engagement and Representation Committee, or the MERC. We can see here that the MERC picked up the baton from the council last time round in respect of the membership priorities for 25-26, and started to think through then actually how we would go about delivering those together over the course of the year. So you can see the content there on the page 7 of the report, and I'll draw Governor's attention in particular to the section in the middle where the MERC is seeking your help and support, and we've identified 3 areas there in which we think governors could make a contribution. So if you're reading any or maybe all of those actually feel you could help, please do drop us a line using the usual email address, or indeed drop a note in the chat whilst the meeting's going on, if you prefer, to let us know that you'd be interested, and we'll reach out to you to have a discussion about how you could get involved. So beyond the work of the MERC, the membership group, I'll just also highlight the continuation of our successful pledge programme. Governors will probably recall we won national praise for introducing the pledge programme, and are looking to keep it fresh and effective as we move further into 25-26. Hopefully everybody's received the metaphorical tap on the shoulder to make a pledge again for this year. If you haven't yet had an opportunity to do so, then do please drop us a line to let us know what you're planning to achieve over the course of the year, and indeed let us know if you need any particular support, so that we can factor that into our plans. And then finally, just really to highlight the upcoming events and meetings for governors, the dates of which you can see on page 9. So I think with that, Christian, in the interest of time, I'll hand back for any comments or questions and really seek the council's approval for the updated draft terms of reference for the Standards Group. Thank you.
Thank you very much, Richard. Are there any comments or questions at all? Julia, please.
Thanks, Christy. Thanks, Richard, for a comprehensive report. I didn't interrupt when you were talking about the Stay and Thrive event, because I know you were waiting for governors to come in, so I thought I must just give a brief comment, if I may. It was an absolutely amazing event, and I think there were 3, if not 4 governors there, which was fantastic to see. And actually the NHS England lead for the programme, Stay and Thrive, which supports our internationally educated nurses, Mark Doblas, was there, and I sat next to him. I didn't realise, but I sat next to him at a table, and he said he'd never seen anything quite like it. I think the level of support that was given by NHFT, and the level of thinking about the people coming from different our staff coming from different countries and what that might mean for them. There's a huge amount of support for them. And it was just fantastic. We had some amazing cultural experiences. I learned an awful lot. And I think the overriding impression I got was be very, very thoughtful about how you include people coming from different countries, because it's not the obvious things, you know, and some things people shared their experiences that they found very difficult, and learned a lot about, you know, just thinking about how we do actually support people. So brilliant event. Great to be there, but really good to see some of our governors too. And yeah, a great celebration. Thanks very much.
Thank you, Julia. And actually, worth mentioning, I think Heba might have been in the photograph, if I remember correctly. But Heba, it's part of Heba's role, if I remember. Heba,
Yeah.
for those who've not met her, is one of our staff governors, and she's involved in that. And I think some of you will remember she did a staff governor story and actually talked a little bit about some of the challenges for some of our international staff in onboarding. So this kind of, you know, the approach we take to supporting staff to settle in, we all know induction is incredibly important into any organisation, but what this recognises is the additional ask of any organisation bringing in colleagues who perhaps have, you know, are actually new to the country, not just new to the organisation, because that adds a whole other level. So so really good to hear about that programme. So yeah, I would like to add my welcome to James as a new governor. James, look forward to hearing from you in due course. No pressure, but it'd be lovely to hear a bit about your background as well at some point in the future, and give you a chance to share a bit of your perspective as a member of staff as well, because I think that's always particularly rich.
Thank you.
So I think, Richard, you were keen for us to approve the standards group terms of reference, which the group has obviously reviewed. A copy of that is available at Appendix 6. Can I take it that colleagues are happy to approve that? Because it is the council who has to approve these terms of reference so they can be enacted by the group going forward. Everyone okay with that? Yes, great, thank you. There is a slight, just a very small misreference, if I can describe it at that, Richard. At the bottom of the appendix says draft May as reviewed by COG nominations remuneration. I assume that should say it as reviewed by COG standards group, but it's a very small point, so we can we'll just note that that's probably just a minor error, but I just wanted to highlight that as noted so that we can amend that when we take the reference terms of reference forward. So thank you very much, everybody. That moves us on to session 2, which is updates from myself and David Mayer as deputising for Angela today. There are a couple of things I wanted to bring to your attention. We don't normally circulate or present the full chair and chief executive's reports that have gone to the board, but do want to take the opportunity to highlight a couple of things, and I'm sure Dave may do the same or talk about a little bit about what's sort of top of his agenda at the moment. But I wanted to let governors know that all the non-executive director appraisals have been, discussions have been done, and I'm just working through the process of making sure they get written up, and we'll be providing evidence to the Nominations Remuneration Committee of the Governors about the conclusion of those, and a summary will be presented to Council in due course. So that's just to let you know that's in hand. The other thing to say is that the Nomination Remuneration Committee, always a bit of a mouthful, NomRem for short, met on Tuesday and shortlisted some non-executive director candidates for a recruitment process that you're aware that we're running at the moment. So we'll obviously really delighted that a number of governors will be involved in that process. It's taking place, I think, on the 16th and 17th of June. So council will be hearing in due course around that. The other thing to mention is I went to a Together Against Racism event, and indeed several governors were in attendance there. Heber and Richard were there as staff governors, but also Monica and Marcella were there as public governors. Monica, feel free to come in if there's anything you want to say about that event. I think you heard a little bit about the programme of work that's going on around our sort of anti-racism programme. So I'll let you come in if you'd like to. Just indicate if you would, and we will do, but don't feel you have to either. The other thing to mention is I'd like to bring Carol in, if that's okay. Carol Phillips as our chair of Nominations Remuneration Committee, because at the not this one but the one before, we presented some evidence around fit and proper persons, evidence for our non-executive directors. Carol, are you happy to make a comment about that?
Yes, that's fine, Krishni. This was presented to non-rem at the meeting, not last meeting, which was Tuesday, but the meeting before, and we were assured that the proper process had taken place and that all the people on the list were fit and proper people in the terms of reference.
Lovely, thank you very much, Carol. And just to confirm, so non-rem look at the non-executive director evidence. We've got an executive director board nominations remuneration committee, which looks at executive director appraisals, and that's chaired by myself and attended by the NEDs, and we will be looking at the evidence around fit and proper persons for exec directors. So we'll be able to submit a final report to the region that we have concluded that process, which is an important step we need to undertake. So just wanted to let you know on that front. If there are no further comments or questions on anything that I've said or Carol has said, then I will hand over to Dave to talk about your perspective, Dave, from Chief Executive and Executive Directors.
Great, thanks, Krishna, and hello everyone, and thank you, Michael, for such an inspiring story and introduction to this afternoon. So just a few things to pull out from the paper, as Krishna said. It's hyperlinked in the invite. We've participated in. What I'll probably do, Krishna, is probably just give a sense of kind of the national flavour, then kind of focus on some of the internal things that are occupying the exec team, and then I'll finish off with some of the local system work. So nationally, there's a process which is due to conclude this month on the new performance framework for the NHS, which brings to life, I think, a few things which we're doing quite well on. Certainly length of stay in our services being a priority for the NHS going forward, so that we can increase flow and capacity in services, and we're performing very well in that, partially because we've been able to free up beds to ensure we don't need to place patients out of the county, which is again very important to the experience of people who use our services. There's also a expectation that we will reduce the number of patients with a learning disability, or as Michael has helpfully said, people who use our services with a learning disability who need an inpatient bed, and we're actively kind of working on that locally. Also, part of it is a new focus on inequalities and population health, and we've got some really great work happening in the trust around our inequalities work, which in due course we'll bring back through here. I'm particularly focusing on some of our frail communities, which of course for Northamptonshire, that is a big feature of our population with increasingly older population. Part of the expectation on the performance framework will also relate to our financial delivery in terms of our plan, which of course links to our Value in Healthcare programme, which we've had a very successful year last year with full delivery of our plan, and we expect to deliver our plan this year, which of course is a stretching ambition as the NHS begins to really begin to look at where there's variation in workforce configurations, and we're tackling that full on with our group. We've got a group director of digital now in place across the two organisations, and there is an expectation that we will look at further opportunities from our corporate resources to begin to manage to bring into reasonable benchmark our numbers of staff numbers in those professional groups. That then allows us to focus, of course, on maintaining robust, safe clinical frontline services. So again, we welcome that balanced focus that the NHS nationally is asking us to take in terms of the financial challenge ahead. Just moving on then to some of the other national work. Anne and I, our Chief Operating Officer, joined an urgent and emergency care launch event today, which is the plan for the NHS going into the pressures of winter, which of course we're beginning to head beyond that when we start entering into summer. And that again has a big focus on length of stay, admission avoidance with our intermediate care team. I did a service visit to them yesterday, really inspiring service, you know, working diligently out in people's homes and in local communities to prevent admissions, trying to keep people at home as much as possible, and then supporting individuals to move back quickly if they are admitted into an acute bed or indeed one of our community beds. So really inspiring work happening there, and I feel we're in a really great place with heading into winter. Equally, and I know Anne may comment and chat on this, we've began to open up and move some of our resources into Spinneyfield, which is a recovery independence unit in the county. And that again is a new set of capacity for the county as we head into the pressures of winter. So again, we're actively working to support partners and support our patients with the challenges as they present themselves through the course of the year. So just to move into thinking about the trust then, so we're actively as an exec team looking at our refresh strategy, which is now a group strategy across the trust. You'll see it in our backgrounds, focusing on Thrive, which I think gives us a really helpful framework now to engage our staff and our communities about our ambitions for the future. And the feedback's been really great from colleagues who've been involved in it, and we will continue to develop those plans over the coming year. So many thanks to the teams who have supported us getting that strategy in place. Just to focus a bit on our Freedom to Speak Up work, we've had a new Freedom to Speak Up Guardian join the Trust, Luke Sullivan. He also works in NGH as a Freedom to Speak Up Guardian. So that's a really positive contribution to both partnership work in terms of listening to staff voice and being able to, you know, feel the pressure points for individuals and be available as a confidential point of contact for people who want to raise concerns. And he joins Beth Brand, who is dropping down to 3 days a week. So that gives us a full cover of Freedom to Speak Up cover across the trust. And then just to conclude, Krishni, in terms of system working, there's an expectation that ICBs, integrated care boards, as part of their move to reduce management costs by 50%, they will now begin to what's described as clustering at a regional level. And I know that's in the media covered today. Northamptonshire and Leicestershire are expected to cluster their work. We feel optimistic about that as an executive because we've already got Angela working in a group role with Leicester. We've got a number of group roles in the trust now, David Williams, Paul Sheldon, Gareth Jones and others working in a group model. So, and of course yourself, Krishni, as a group chair. So we feel really optimistic that that is a model we can work with, and we've already made good strides in developing those working models across the two counties and the four large places being Rutland, Leicester City and Leicestershire County and Northamptonshire. And then finally, just on Michael inspired me to reflect on the volunteering week, and we had a social value event in Northamptonshire yesterday. I hosted it on behalf of the system. It was brilliant. We had really passionate stories from Volunteering Impact Northamptonshire, who are our volunteer network provider. We had Brightways, who are a sustainable transport social enterprise and also host the social enterprise Northants network. And we talked about our work in secured services, driving social value in our communities. And yeah, it was a real bounce to the opportunity, and it really felt like people could see better outcomes for our partners and for our communities through partnership working and coming together to plan and do the work that we do differently for the future. So I felt really optimistic coming out of that, and people have emailed me since saying they feel there's a real exciting opportunity ahead of us in this county for 25, 26 and beyond. So I share that just in the spirit of optimism and to reflect Volunteering Week.
Thank you very much, Dave. Yes, that's I'd forgotten the conference was on yesterday. Unfortunately, I couldn't join it, but it would be great to have a little write-up about it, Dave. I guess there'll be some follow-up comms on it, just so that we can share that with people and kind of understand what was covered if people weren't able to go. So that's really helpful to hear. Dave referenced our Thrive strategy. I think I just wanted to, in case you couldn't read the backgrounds, we've all got the sort of backgrounds which show, and many of us have, with what does the T stand for, what does the H stand for, all of that. But I've just included the link in the chat in case anyone wants to dip into that. But it is, we are sort of actively promoting the Thrive strategy because it's new. We've launched it with our group partners in LPT, and it's certainly people who lots of our staff and partners have contributed to its development over quite a period of time now. So it's very exciting to be able to just share that refresh strategy with everybody and use it really to drive our focus going forward. So just wanted you to be aware that it was out there, and it will be something we'll be referring back to. Anne has put in the message. I don't know, Anne, if you want to come in, but just talked about the move to Spinneyfield being very exciting with a purpose-built provision. So really sounds like a great opportunity. And I guess I just really wanted to connect what Dave was saying about the intermediate care team. I'm pretty sure there's been some videos about the intermediate care team recently. I'm sure that that's something that we've shared through the Chief Exec's report. And it's, it's admission avoidance, if you think about it, which is something we've touched on, is very much in keeping with acute community, which is one of the government's 3 shifts that everybody keeps talking about. So how do we keep people out of hospital? And that's really about making best use of our community services. So, Anne, did you want to come in briefly? Don't feel you have to, but I just thought you might want to.
Yes, no, it's been really exciting couple of weeks as we are starting to see our winter plan for this coming winter start to come into realisation. So some of the big parts around that were around Spinneyfields, and this is, as Dave said, a purpose-built building that has enabled us to move some of our existing beds into this environment, which is much more suitable, but also enabled us, as we move into winter, to be able to expand and really grow that provision to manage the demand that we're anticipating in the winter coming. But that is not sufficient. There's also the work that's happening in our ICT team and how we really develop that model of what we can do at home. And the teams, I've also been seeing them recently, and as Dave has, they are very enthusiastic. There's a lot of innovation and really keen to see what is the art of the possible to safely manage people in their own environment. So we are taking forward some of the key areas of the plan in Northamptonshire for winter, alongside UHN, our colleagues who are looking at the systems inside the hospital, but definitely feels like a step forward this last couple of weeks, which has been really good.
Great, thank you very much. Are there any questions about anything that's been covered in those reports or comment? If not, happy to move on to the next item. Michael?
Thanks, Krishni. I think it is really a comment, and Dave, thanks very much for that overview. I think my comment is that it's as you all know, it's about not underestimating the challenge of all this system change, and I think particularly with the integrated care board, and I know with another hat on how that is causing a lot of disruption. And I guess it's really, it's not necessarily about an answer now, but I guess it's how you as a senior team sort of really are able to provide that safe space that you obviously need to have in terms of having some of these discussions about the change and the insecurities that will bring. And I think in terms of the group role that the organisation is taking as well, because there's always a drift down to different levels of staff because they'll be very unsettled and very unnerved about what they're hearing. And, you know, there are some organisations who are talking about significant reductions in their workforce. So I think I just raise it because I think governors need to be aware of that, and also the impact that has on you as a leadership team. And it is about providing those safe spaces for people.
Thank you very much, Michael. Very important comment. Dave, I think you'd like to respond, or at least
yeah, thanks, Krishni, and yeah, thanks, Michael. A really supportive question. I think for us as an exec team and as a trust, we do see both a future working in group at the footprint we've described across Leicestershire and Northamptonshire, but really passionately about neighbourhoods and place-based working close to people's home. And Krishni knows I love the quote from Nigel Crisp, health is made at home, hospitals are for repair. You know, we believe in that really passionately. That grounds us. And we've already configured some of our mental health teams at neighbourhood level across 9 different geographies. We'll be doing more of that locally. So yeah, you're right. We've got to keep an eye on the big picture at regional level and of course national, because we do provide services nationally in terms of our secured services work, but equally we're completely grounded into neighbourhoods and place-based working. So again, I feel really excited about those opportunities, and I think that's a really helpful and supportive question too. So thank you.
Thank you, Dave. And actually, Adam commented in the chat about the greater ICB footprint and opportunities for economies of scale, but also that concern about potential sort of less localization. But interestingly, of course, you know, a lot of the conversation is about increasingly, well, the language at the moment is about neighbourhood health, and that sort of sense of more really ICBs, integrated care boards, focusing on more outcome-based commissioning, but particularly making sure the needs of local populations are met. So it is interesting. On the one hand, it's sort of rationalisation, but on the other hand, it's a more focused role. And I don't underestimate the challenges of the transition for people, because after all, staff are affected in some of those changes. But equally, I think the focus on neighbourhood health is really welcome, and certainly kind of a greater focus on you know, really improving the health of the population, which is really what Darcy highlighted we hadn't been doing adequately, I think, as the NHS as a whole. Dave, final comment then from you.
Thanks, Krishni. You reminded me on the people bit about the mental health commissioning team have, you know, well over a year ago now, transferred into NHFT as part of our leadership of the Mental Health Collaborative. So we do see again a future for us being able to provide that kind of leadership in commissioning and collaborative commissioning leadership. So again, it's an opportunity for us to really drive home some of the things we're passionate about.
Great, thank you very much. Thanks, Dave, and thanks to Anne as well, and for the questions and comments from Michael and Adam in particular. So we move on then to the final sort of main item that we have on our agenda today. And as usual, we've got a session with a couple of our non-executive directors kind of walking you through some of the assurance discussions that have taken place at board meeting. We particularly wanted to bring back to you the review into Nottinghamshire healthcare. I'm sure Robin and Joe will talk about this. We have covered this, we have brought this to you before, but actually it felt important to bring an update to you. So I'll hand over to Robin and Joe, who are going to take us through this, and I'm sure other colleagues will come in as well to support them. Thank you.
All right, good afternoon, everybody. Really nice to see so many people here today. You'll recall that I presented about this in a previous governors meeting, and I do this as the Deputy Chair of the Quality and Safety Committee, and Quality and Safety is the primary committee which has a kind of oversight role feeding up to the board on the kind of assurance on what's being done in response to the Calacain case. And what we're going to do today, I'm going to start off today and then Joe's going to join in and then we'll come back to me at the end, is talk through the latest stage in this. Because this is an ongoing process, but this is very much another part of this. I don't need to go through all the history. We all remember the very sad events that happened in Nottingham in terms of Calacain and the crimes that he committed when he had effectively disengaged from services in Nottinghamshire. And following those events, there has been a lot of requirement upon trusts to really examine their practice, to work with their partners, to work with other organisations, to come up with a kind of integrated set of proposals which are going to address some of the issues that have arisen. And what we have today is very much a system response to those issues, because we saw back in February, the government published the independent review into the cases, and it was a hard read. Let's be under no illusions. It raised some really serious points for mental health trusts and other organisations in terms of how they organise care for people who are disengaged from services. And following that, they put a requirement out to all trusts, or rather all systems, to come up with action plans for how we would address particularly issues to do with intensive and assertive community treatment of people. Because ultimately, although the Calacain case was a matter of deaths that arose, we shouldn't dwell on that. What we should dwell upon really is that this is a matter of managing risk, and particularly risk involving people who are disengaged from services. So really the focus upon what we've been doing as a trust with our partners since that, as part of a broader system, our ICB, is very much about looking at management of individuals, not just thinking in terms of the most acute response that may occur, like deaths, but looking more generally about what may happen and how that can be managed. So thank you. I was just going to say, can we have the next slide? As it says here, NHS England asked all systems to review how, in particular, systems manage their intensive and assertive community treatment action plans, because this was the nub of the issue, that Calacain had disengaged from services and he posed a risk. So we needed to come up, all trusts, all organisations, all systems needed to come up with a credible plan for how we were going to look at this, triggered by the Nottinghamshire cases. As this slide said, it builds upon a requirement in the 24-25 planning guidance for all ICBs to review their community mental health services and to ensure that they have clear policies and practice in place. And indeed, trusts and ICBs were required to ensure their action plans were updated and discussed at public board meetings no later than 30th of June. And those of you who were able to join us as observers for the board meeting last week will have seen that we did discuss this. We did discuss our response, and we highlighted there that we would be bringing this to the governor's meeting today. It will also go on to the ICB. It will go on first to the Quality Committee, which I sit on for NHFT along with Linda, and then it will go to the full ICB later on that week. So that was all we were required to do. So I'm going to hand over now on to Joe, who's also a member of the Quality and Safety Committee, who's going to talk you through some of the detail of this, and then I'll come back at the end.
Good afternoon, everyone. So the slide here just gives you the headline issues that were identified as the main areas for focus for the systems. And the first one, Robin's already highlighted it significantly. It's about how partners evaluate risk. This isn't as a collective nebulous concept. It's literally risk assessing every person at every stage of their treatment. As we saw, horrendous results if this isn't managed properly. The second point for specific focus was that stage when treatment is ending, how a person using services, to pick up the language from previously, how the person who's been using our services accesses then enduring support as they transition back into a community without the wraparound of NHS service provision. This has been proven to be quite a critical point in long-term success for people. If their discharge arrangements work adequately, they have a safe, secure environment, they have the support around them of family and friends, it ensures that they stand a much, much better chance of long-term good health rather than ongoing issues with their mental health. The third strand was absolutely front and centre of the work that has to be done, which is around multi-agency working and removing the language. This is basically how different public agencies and the third sector work together. And for anybody who's ever been involved in multi-agency working across the public and voluntary sectors, central to this is that age-old problem of information sharing. The fourth area for focus was around the support network that exists around patients and people who use our services. Often it's family, not families all the time. So sometimes it's around friendship groups and how the wraparound support can be given by that network of people to help the individual, both during treatment, but also as they transit out of treatment. And then the fifth strand for focus was something which Dave's already alluded to in his presentation, was around out-of-area placements. This has been a problem for a number of years in various parts of the UK. We're doing a lot of work locally to reduce the need for out-of-area placements, again, because it takes people away from their support networks. So if you could have the next slide, please. Now, what's been evolved is an action plan to try and address those 5 major strands. And just before I get into some of the detail, it's really important to understand that this hasn't been prepared in a dark room by one partner alone. And in Northamptonshire, it's evolved from a series of workshops which took place to bring all partners and stakeholders together to understand where the gaps were, to challenge each other, and so that we could end up with a comprehensive picture. And various tools have been used to ensure that we're able to compare our own situation to other parts of the country. So, and I'm afraid it's sort of NHS language here, but there's a tool being devised called a maturity index tool. And basically, it's a means by which we can assess our current position, and it will then allow us to compare ourselves with both other systems regionally, but also national comparisons. And that tool has been devised around a series of questions, and we can then score ourselves against various situations. So what's emerged from that process of workshops and collaboration and assessments has been an action plan based upon tackling those items I've just run through on the previous slide. Front and centre of this is obviously the people at the front end who work with patients on a day-to-day basis, and ensuring that they have the well-rounded set of skills which will allow them to do particular aspects of risk management, risk assessment, but also to enable them to properly engage with families and support networks. and ensuring that staff skills and competencies are kept up to date and developed and evolved as they need to meet the needs of the treatment plans. The second strand of the action plan is around a more intensive approach to community treatment. And the language that's used on the slide, and I've asked people to, so I can understand this, is around assertive outreach and assertive community treatment. So this isn't a new concept. This is something which a lot of agencies do in very different ways, and it's something now which, given the situation that's happened in Nottinghamshire, particularly where people disengage from treatment, is where services, organisations such as our own, actively seek to persistently approach people, even if they disengage with our services. So almost pursue them to ensure that all of the agencies that need to be involved with that person stay involved with that person. There are parallels for rough sleepers, for drug users, but in this instance, it's mental health, a mental health focus. And that's a really, really important part of the action plan. So the third strand is also around caseload, to ensure that all people working with these very, very complex individuals with particularly difficult needs and that ongoing need for risk assessment have got a caseload that is manageable, because without having a manageable caseload, the degree of ongoing supervision is very, very difficult to balance. So the fourth strand for the action plan, and I've alluded to it earlier on, is the arrangements for discharging a person from treatment, from ongoing treatment, and the idea of defining a new model pathway for discharge across all agencies. So again, if there is an ongoing need for support in various partnership, if there are housing issues or drug alcohol issues, they're picked up and managed as a joint discharge arrangement, so that no one strand of that individual's care is left unattended. The next element of the action plan is around this notion of disengaged patients, people who don't turn up to their appointments, and ensuring that we have a consistent approach to that. And as I've already alluded to, that persistent chasing up of people, that concept of assertive outreach. The next point for the action plan comes back to the concept of the multi-agency working, so different public agencies working together, and I've got lots of personal experience of this, critically around ensuring that we all have a common language, that we have training that supports complementary work activities, but also for people with severe mental illnesses, that element of information sharing, so that the key agencies involved in that person's care, supervision, whatever language or whatever role they're playing, have a full view of all of the information at any time, so that everybody can understand where the risks are, or if the risks are changing, how we react to them. And the final strand on the action plan is around waiting list management. And this is an ongoing problem that has to be managed. And again, there's lots and lots of work going on behind the scenes around how the waiting lists are managed. There's weekly meetings within the exec teams to ensure that people are managed well while they're waiting, and the concept of waiting well, so that they get the support and direction that they need during that phase of waiting. And obviously, given the risk assessment that's going on, the waiting list can actively be managed based upon risk profile. So if we could have the next slide, please. And as Robin's alluded to, we saw a paper at board last week around this, and this is the most up-to-date statement of the position of NHFT with regards to that action plan. And I won't go through each strand separately. The progress column on the right-hand side is the current status of the NHFT position. So as you can see, the multi-agency work, which is that first point there, is ongoing. It's currently in place. The dynamic risk management is in place. Staff have been suitably trained, and again, that's an ongoing process. So any new staff joining teams will be trained thoroughly, and staff within the system will be updated regularly. The second strand is the joint discharge arrangements, and again, as you can see, lots of work being undertaken on that. QI, quality improvement projects, and again, the standard operating procedures are ensuring there is consistency in how things are handled. The third strand is around multi-agency working and the information sharing. And again, lots of work going on, lots of positive developments on this. And the approach that we're trying to encourage here is that notion of no wrong door. So whichever way you go into the public system, whether it's through the police, whether it's through fire, whether it's through primary care or secondary care, that they will be channeled into the right place, and that the whole system will then respond to that individual's needs based upon whichever treatment path is the right one. The fourth strand, again, is that element of working closely with families. That's in place and is being developed all the time. The language that's been used in our local action plan is a golden thread. So literally from every part of the system, there is a golden line that takes in family, friends, support networks. So the individual is properly supported during their treatment and after they exit, and that we have a full connection there and understand the support mechanisms that they have in place. And then the final strand of the plan is the out of area placement. And as I've already alluded to, lots and lots of really positive work on this to ensure that we have capacity within our local geography to manage this successfully. So I'm going to hand back to Robin to put the final point, to point you towards the chat. Anne has given a quick update on the maturity matrix. But back to you, Robin. Thank you.
Thought I muted. I would say up front to say thank you to Linda, Anne, and I suspect Itai, although it's Sashin here today, who have contributed to all of the work that has gone into creating this action plan and indeed is distilled in these slides. And now a lot of you will be thinking, okay, there we are, we're going to do all this stuff. There's a really good action plan here, but how can we be assured that this is really going to take root and that we can be assured that things are going to change? How is it going to be monitored? So this last slide is very much about this, because it's not a straightforward process. It's not like there is a set of obvious data sets which show things like the degree to which families have been involved in the care of individual people within CMHTs. Such data sets don't really exist. So it is a much more looser, much broader set of indicators which are used to offer that kind of assurance at board level, and which monitor the work of execs and their teams, and which can be therefore used to offer assurance that this plan is really going to take root and make a lot of difference, and then on to yourselves as well. Now you've heard a little bit of it in the last slide. You heard about a clinical audit in particular, which is going to look at some aspects of it. And it's that kind of data, that those kind of audits, those kind of QI programs that we'll produce, that will come up through QNS and offer us assurance that there is real work being achieved in all of these areas. And ultimately, as I said at the start, it is QNS, is the committee that fundamentally reviews all this, and the executives produce up for the group really comprehensive and detailed reports illustrating the various aspects of achievement against action plans of this sort. And something like clinical audit is just one tool that's available to monitor success in this kind of way. It is important to say that it also goes up through the ICB committee meetings, because this is about our accountability as a trust to our commissioners. So it is important that it is dealt with there and we are able to report on that. And that will be Linda, who attends that committee, and I attend as well. And we offer up assurance to the wider system as a whole. But there are many, many other ways in which assurance can be given. And service visits are obviously a key area. Our CMHTs are a really crucial part of what NHFT offers. So service visits to them do offer that degree of assurance, and detailed and probing questions can start to get under the skin of how much we have addressed a lot of these issues. But there are other sources as well, such as it says here, feedback from service users and their carers, things like IQVIA and others. Indeed, the annual Community Mental Health Survey does give some data. I know this is only an annual thing, but there are the ongoing dynamic processes of IQVIA and others also give information. Patient stories at board are another way in which you can be assured and others can be assured that issues of this type are being substantively addressed and the plans are being monitored. And as I said, there's a degree of dashboards and data sets and benchmarking that can be drawn upon, but it is part embedded in the much broader sets of data that come up to QNS. But I'd like to draw your attention in particular to the fact that if you look back to the minutes of our meeting in April, you'll see there a really, really detailed session which QNS put into the review of community mental health teams as a whole, because as has been said, there has been a great deal more that's been done to reorganize teams, to make them to be more accountable to their local area. Dave reported on that just now. And in the session that we held then, which was a really substantial session, we looked at this in real detail. And if you want to know more about that, have a look at the minutes of the QNS meeting from April, which then in turn went up to the last NHFT board meeting as a report in terms of what we do. And so there's a great deal more about what has been done that's available there. And as this slide concludes, there are also staff survey results, because it is really important, of course, to get the feedback from staff about how effective these procedures have been. That's the end of our presentation today, so we can take the slides down. But I'd certainly invite any questions that people have had. I think the question that Adam raised was really useful. Pleased to see Anne come straight back in with that. And I would hope that Anne and Linda and possibly Sashin will also join in if there are any inquiries or queries that we can't answer, because as we've said, this is very much a product of executives and their teams. Richard is also very much involved in this as well. Okay, we have a question I see already. Krishni, do you want to take over?
Thank you. Thank you very much, Robin and Joe. Very comprehensive. So a couple of questions that colleagues would like to ask. So first of all, Mark, please, Mark Major.
Yeah, thanks, Robin and Jan. That was really comprehensive. So I suppose just a few observations and a couple of questions, really. So unfortunately, whenever you see serious case reviews or serious incidents like this, they have a depressing set of commonalities that are within them when you look across them, and missed opportunities is a phrase that kind of comes up to some of that to some of that up. When you look into the case in Nottinghamshire, one of the things that's clear is it wasn't an isolated case. There were other people under their care who committed serious offences as well. So you've got something that's systemic there as well. So there's a good lesson there, isn't there, about making sure that our systems are good and fit for purpose. Just a few other bits and bobs. It mentions a lot working with families. In that, I'd say that listening to families is absolutely vital, and I suppose one of the key questions, and we might have some very good answers to this, but you gave some examples of how we listen to families. How do we facilitate families when they're trying to raise significant concerns, I suppose, is a question there. And then a few of the bits that were really quite pertinent in what you were saying as well. It's the role of integrated working, but not falling into the trap of integrated working and think something is somebody else's responsibilities, and not any organisation that's leading on things. There's a really good point in all of that, isn't there, about how important the investment in frontline staff is in terms of training as well. And I suppose the other thing that struck me, and it's not kind of pertinent only to this case as well, and it's the role of, when we're talking about integrated responses and offering the best set of things we can for people, that not to just fall into the trap of thinking that that's just health and social care services. That can be voluntary sector services as well. And actually, social inclusion's a really powerful tool in terms of, as we all know, in terms of helping people to manage their mental health. So sorry, there was a few bits there, but I just thought that was really comprehensive and very helpful. Thank you.
Thank you very much, Mark. And you know, you're absolutely right. I mean, your observations are very sharp in relation to sort of some of the learning from this, which is why I think it was really important for all of us to undertake the sort of, you know, following the CQC's review and sort of, you know, identification of improvement opportunities for everybody. That's why it was really important that we did our own learning from it. I think particularly Mark highlighted a question about working with families and carers and listening to people's concerns, because I think that does come out sometimes, doesn't it, as a bit of a theme that certainly people have raised, not necessarily just in this case. So just wondered if you wanted to comment on that particularly, Anne, or indeed any other thing that Mark has highlighted.
Yes, no, I think I particularly picked up the working with families and carers, Mark. It's such an important part of care. And when we remember that this is about working with people with a severe sort of mental illness who are struggling to engage, it's a particular approach, and often family are central to that, because engagement is such a challenge with the service user at the time, whether that's in crisis or whatever. So we have been doing some work, as you will know, of developing up our carer peer support workers, which are really key to some of our critical parts in the system, particularly around some of our wards, but also our crisis pathway, which I think is where we need to be really engaging people in being entwined in that sort of care plan, assessment process, and understanding what the risks are and how they're perceiving things. We always know that there's often times and then when people don't want us to share information necessarily, but that never stops us from listening to what carers and family have got to say. And that's an integral part of the risk assessment. So it kind of links the risk assessment angle and the importance of carers into the core of what we need to do in this work. We are looking at all of our processes in light of this, of how we hear carers, how we understand from things such as Carers Corner to individual care plans that include the carers' views and thoughts and feelings. And one of the things that we've had historically, and we're just sort of reviewing again, are different tools that there are to help with that. For example, like the triangle of care, but just really understanding where we're at and benchmarking. So I think some of our work, which was supported very much more on carer development, has been really important and has given us a sort of a springboard to work from in a lot of this work. Can I just mention training? Is that okay? Because I know you mentioned training, Mark, for frontline staff. I think this is really key. I'm a little bit old school in that I've been around for one. They used to, back in a long time ago, there was CPN training, which was community psychiatric nurse training, which equipped you to go out into the community. And that's sort of a thing of much of the past now, but I think there's some elements of going through that very sort of standardized approach to how you work in the community that are really important. And I'm glad to say that we've really taken that on board. And there are so many, with the shift to more community work, naturally there's so many more people working in the community and we want to support them. And so looking at people who have the experience and qualification to support who we have in our organisation has been key to sort of responding to this action plan.
Brilliant. Thank you, Anne. You mentioned Carers Corner. I seem to recall one of our staff governors who was involved in the council was Dr. Krishna Yatharaj, who I don't know if he's still leading on Carers Corner, but I know it was something that he worked very hard on, so it was good to hear that it's still going. I know that Linda and Sachin would like to come in, but I'll possibly just bring Jamie in James in, because there might be something else that Linda and Sachin might need to help me with as well. So James first, and then we'll come back to you, Linda. James?
Sure. Yeah, thank you very much. It's just one thing that pricked my ears up, and I just wanted to understand a little bit more. It was in relation to the sort of waiting well initiatives and how that's being managed. Obviously, I work in physiotherapy, and we've got long waiting lists and people that access care. And I just wanted to see if you're using any software or how that's being translated, so that we can see if there's any learned or shared things that we could implement within physiotherapy as well.
Lovely, thanks, James. I'll let, so I don't know if Linda or Sachin can comment on that, but I'll bring you in anyway. And then if anyone else wants to comment on that as well, that'd be great. So Linda?
Thanks, Krishna, and good afternoon, everyone. I just wanted to touch on the previous question that was raised around how we engage with families and carers. So this is one of the integral things that we need to do, to listen to families, carers, and significant others. So what we've started out to do in NHFT, which was part of this work and pre that, is to ensure that we've got the right contact details. So you'll appreciate that some patients will have moved, could be estranged from their loved ones, but actually their loved ones know them really well. So we always want to ensure that we've got those details, because sometimes the failure to engage is because you don't know who to engage. Within the multidisciplinary team, where patients will have a regular review of their care with them, family, relatives, friends, carers are invited to be part of that, to contribute. Where patients are very unwell and they don't want those people in the meeting, it doesn't stop us from engaging them. We'll engage with the patient, but we'll still see their significant others separately so that they can contribute to that care. We've also got lived experience advisors working in the trust who spend time working with us as staff, supporting us through training, which is what Anne has already mentioned, but they also play a key role in speaking to our patients. And part of those conversations, they've walked those steps, so they're best placed to actually encourage patients to work with us, to have their relatives and families provide us input. Of note for us, we are a learning organization. So part of what we do when we review any serious events is to look at those areas around the engagement, so that where we need to improve, we are learning and we can make those improvements. So we continue to learn through that. With regards to the next question on waiting well, we've had a lot of information presented around waiting well, particularly for our children, young people. So we've had that presented before. So I'm happy to go offline to then provide you with some of that information. We keep up to date with those on waitlist, because there's an active group of the waitlist management group. And part of that includes sort of the data cleanse, because some people might not require service when they've been waiting, but actually there's a process that's involved in that. So if you'd like us to then catch up outside of the meeting, I can provide further information on waiting well, and actually provide the link colleagues who have done that work in practice. Thank you.
Thank you, Linda. I'd like to bring in Sachin. So Dr. Thankar is covering for Itai, our medical director today. So welcome, Sachin. I haven't seen you here for a little while, so nice to see you here. And I'd like to bring you in now, please.
Thank you, Trishni. I just want to kind of develop on the previous answers given and answer the questions. I think when Robin was doing his presentation, he kind of touched on a very important concept of this golden thread, and that is really what we are trying to embed in our services in Northamptonshire. So, people would often say, oh, why are you getting peer support workers, or why are you getting a crisis cafe instead of putting all your resources at the higher end? It's because patients can be, treated and managed without them hitting crisis point all the time. And I think that is the learning from a lot of this stuff that is happening in Nottinghamshire, where for acute episodes, this person was coming in and being discharged. So clinically, the question we need to ask ourselves is, whose patient is this, and are we following clinical logic? So somebody who has schizophrenia is not going to get cured of schizophrenia. So why are you discharging him out of your service as if it was an episode of care is all that is needed? Similarly with dementia patients, similarly with patients across the spectrum. So this is a change we are bringing throughout NHFT. And so that when the patient is terribly ill, so we see him maybe in an inpatient ward, but then we have peer support workers, we have the crisis corner, we have the crisis cafe, and that is the golden thread that we are developing. That is how we are ensuring that this patient who came to us in crisis is managed to the best of our ability. And in terms of training, I think that is the biggest kind of, as a doctor, I can tell you, that is the biggest change that I've had to undergo and learn from being a doctor in NHFT is this, that, it's not just, okay, patient comes, A&E, you go, give him some medications, go home. It doesn't work like that. You have to be caring for that patient throughout. And I think that is the great strength of NHFT to kind of then when this golden thread came out, it was like, yeah, we are already ahead of the curve. We have already started the crisis corner. We already are talking of peer support workers. So really, we are in the loop with this and talking to patients and carers. So in CAMS, I can tell you, we have family support workers who have kind of had the lived experience of having their children going through the service and now are supporting the others. So, that kind of perspective of looking at things and, being open to everybody and the very flat hierarchy that we have here at NHFT, I think these are our aces that we have in kind of bringing this into play. And again, eternal vigilance, because I think we need to know that, anybody can be ill, and is this a proper safety network that is catching all? It's no point in saying, oh, we have got 50% or 80%. We need to extend to every single patient, and every single clinician must be aware, and that's the training bit. Every single clinician must be aware that these are our patients and they don't stop being our patients just because they've had a successful episode of care, especially with the chronic patients. Thank you.
Thank you, Sachin. That's a really great insight and a really important message, I think, that we'd all absolutely support. And it's sort of really great that you sort of shared your own learning as as part of that, your own reflections from your wide experiences. So thank you. I think Richard wanted to come in. I'm really sorry, but we're going to have to, Mabel, I don't think I can take another question because we are beginning to run out of time, and I do need to bring, I think Richard wanted to come in, and we'll then need to close because there's a session that we need to go on to where I do need governors to attend. So I can't afford to run this on for too much longer, unfortunately. But if Richard could make a brief comment and then we can close the item down. Thank you.
Thank you. Thanks, Krishni. Thanks for the presentation, Robin and Joe. I just wanted to comment on it included something on risk, and I just thought it's worth mentioning that one of the things we're doing here in NHFT is we've embarked on a major change in our approach to managing risk within mental health services, and we're shifting from what we call risk categorization, which was like grading risks in terms of low, medium, high, which really doesn't tell us anything, to what we're calling risk formulation, which we're working very closely with our psychologists on, and that is helping us to draw more comprehensively on the total experience, what support they have available to them, who do they have to call on when they're experiencing crisis in their mental health, and how we help and strengthen them to be able to make use of those support services. So it's just that low, medium risk, high thing was just a bit of a nebulous term. It doesn't really tell us anything, because we've had cases where people have sadly gone on to harm themselves significantly, and they have been graded as being of low risk. So when the clinician is looking at this, already seeing that somebody's classified as being of low risk, it kind of doesn't alert you to ask the probing questions that you need to ask when you're doing the assessment. So the move away from that categorization to what we're calling formulation gives you an opportunity to explore with them in a more comprehensive fashion. What are their risk factors? What support do they have available to them when they're experiencing a crisis? And how can we help them to be able to access those supports? So just wanted to throw that in there. Thank you.
Thank you, Richard. And that, I think, is for those of us who are non-clinicians, I think that really reinforces a greater sense of personalisation in the approach to the individual rather than a sort of generic labelling, if I can describe it in that way. So really helpful reflections from all of you. So thank you very much for adding that rich picture to the work that really is ongoing. And Anne has additionally commented that the learning from the mental health waiting well approach and waiting list management, there is very much a focus on trying to share that across to the physical health and the MSK team, so we can make sure that that's picked up. And I think Tracy's highlighted, Mabel, if there's something you want to either drop us a note about, if there's a question or you want to put it in the chat, we can absolutely pick that up, because I'm conscious that I don't want to keep people longer than the allocated time for this meeting. So I just want to say thank you to Robin and Joe for the presentation, for everybody's contribution and some great questions and really good additional rich insights from other colleagues as well, because this is a really important area for us. It's a big focus for mental health teams, and I imagine will be the subject of CQC inspections to come. So this is will remain a really important focus. So I'm really glad we've been able to bring it to your attention and update you. And if you have any further questions, we can certainly address them. So that brings to a close our public Council of Governors meeting.